with Mayo Clinic, Florida. We are grateful for the opportunity to bring you this information regarding colorectal cancer. As you may have seen, Pastor Rogers is working on. He's sort of the man of all skill here. He's working on the screens for us, and when he gets a moment, we'll invite him up to bring further greetings. However, I would love for Miss Shannon Denson with the Jacksonville Black Chamber of Commerce um, to come up and just share a couple of brief greetings so that we can continue on with the program.
Good evening. I'm Shannon Denson, the president of Jacksonville Black Chamber of Commerce. So I'm thankful for Chelsea to have this partnership with Mayo Clinic and also Reverend Rogers to actually host this spot. I am not the program coordinator, but I'm filling in behalf of her. And so we will have many more conversations with Mayo Clinic in Palatka, Florida. So just look out for the great things that we're going to bring to this city.
Thank you so very much. I also would like to take this time to thank, as we share, everyone who is here present. Thank you for Bethlehem Baptist for hosting this event for us here in Palatka. And just wanted to share a little bit.
Recording in progress.
But Mayo Clinic's Cancer Conversation series, which is what we are here to experience today, is designed to bring physicians, researchers, and communities together to share and learn more about various types of cancer, their signs and symptoms, treatment, resources, and the benefits for participating in research studies and clinical trials. We also hear very directly from our survivors, which we're in for a treat today, and caregivers who will share more about their unique health journey. So these cancer conversations are designed to educate and empower all of us to know our health risks, get screenings as soon as we can, and take our health very seriously. So hopefully as you all came in, you were able to sign in and grab a folder. The folder has lots of great information in it, including the agenda to help follow along today. And we also have a QR code that will help link you to today's session online. We do encourage everyone, even if you are in person, we encourage you to still register online so that you can receive the recording later. But you can do that at your screen with your QR code in your phone. Today we have an engaging program for you, so we ask that you take notes. We will have a Q&A session, and we will give further direction when we get to that part. We also have a survey opportunity for you, which when we bring our moderator up, she will guide you through that process. But it'll be to measure your knowledge before and after the presentation on colorectal cancer. So let's get started. I would like to introduce to some and present to others those that we will bring up for our greetings. We have already heard from Ms. Shannon Denson with the Black Chamber of Commerce, and so now we're going to bring up Mayor Robbie Correa, who is the mayor of this wonderful city, to introduce our speakers.
Thank you, everybody. I'll try without a mic as well. Thank you to Pastor Rogers and Bethlehem Baptist for hosting this and also for being the AV guy. And thank you to Shannon from Jack's Black Chamber of Commerce and Mayo Clinic. It's so great to finally develop a partnership and have that option for the people that live in Palatka. I'm told that I am here to read and introduce the speakers and introduce Nicole Landa. And I'm going to start with Dr. Woodward's bio. Dr. Timothy Woodward is a consultant in the Division of Gastroenterology and Hepatology, Department of Medicine, and Mayo Clinic in Florida. He joined the staff of the Mayo Clinic in 1994, and holds the academic rank of Professor of Medicine, Mayo Clinic, College of Medicine and Science. Dr. Woodward earned his BA at Harvard University and his MD at Mayo Clinic Alex School of Medicine, completing his residency and research oncology year at University of Virginia. He subsequently served as a public health physician at Charity Hospital for Tulane University. His gastroenterology fellowship was completed at University of California, San Diego, and he was selected as a Mayo Scholar and GI Oncology Fellow at MD Anderson. Dr. Woodward's expertise is in GI oncology. As a founder of the Advanced Endoscopic Practice at Mayo Clinic, Jacksonville, his practice incorporates evaluation and management of problems related to the luminal manifestations of malignancy. This includes issues derived directly from cancers, such as tumor-related dysphagia, anemias, and paraneoplastic manifestations of gastrointestinal disorders, and as well as GI sequelae of cancer treatment. He is the author of more than 200 publications, book chapters, and has been a lecturer both nationally and internationally. I'm also going to introduce Mr. Terry Payne. Mr. Payne grew up in a small farm town in central Indiana. He graduated high school in 1980, and like most others his age, took a few classes, but ended up working various jobs. But in those good days, good jobs were hard to find, so at the ripe old age of 24, he joined the U.S. Navy. He went to boot camp and A school in Great Lakes, Northern Illinois, and was designated as electrician's mate. Mr. Payne served for 20 years and retired as a senior chief. In January of 2007, just 8 months after retiring, Mr. Payne was diagnosed with stage 3 colon cancer. He will be sharing his story with us today. He has been cancer-free for about 15 years now, with a few side effects from the treatments. He went back to work for about 11 years before retiring at the age of 57. Mr. Payne does face difficult challenges, but advises anyone not to give up, but try any treatment available to them. Nicole Landa's bio. Nicole Landa is the Community Engagement Coordinator at Mayo Clinic. She has just reached her 1-year anniversary at Mayo Clinic and is responsible for deepening outreach and engagement efforts within the Hispanic community. Nicole will serve as moderator today. Please let's welcome Ms. Nicole Landa, our moderator for the session. Nicole?
Good evening, everyone. Thank you so much for being here. We are so grateful to have this opportunity. So first, thank you so much for the introduction. My name is Nicole Landa. I'm a Community Engagement Coordinator and have been so lucky to be a part of this wonderful team for a year. And first, what we're going to do is we're going to complete our pre-survey, as Chelsea mentioned, and this is going to help us with testing or seeing if there's anything that we learn pre and post the speeches that we have today. So we'll have it available for our virtual members through a QR code, and then we also have a copy included in your folders today. So if anybody needs a pen, please feel free to raise your hand. We also have those as well. And I'll allow just about 5 minutes for you to complete that. So we're going to go ahead and proceed with our first speaker, and that's going to be Dr. Timothy Woodward from our gastroenterology at Mayo Clinic, Florida. Thank you so much.
Thank you all so much. I want to thank, in particular, Reverend Rogers and Bethlehem Baptist Church to have me here. It's a big honor, and I'm a cancer survivor myself. My colon, in this instance, was prostate. But it's amazing over the course of the past decade, even, how much progress we've made in terms of being able to cure people and make cancer, which is once a fatal disease, now a chronic disease, almost like diabetes. And it's amazing when you think about that, just through the sort of efforts of cancer research and such. My talk, this is an area I'm very passionate about. I've been doing community lectures since I came to Mayo back in the 1994. And am I speaking loud enough? Can you hear me? Okay. And normally my talk is about 45 minutes with about 45 slides. and I ain't going to keep you here that long. So what I am going to do is I'm going to sort of hone down into the particulars. And what I'll be focusing on is what cancer is, because my approach in terms of treating people is that an educated patient is a good patient. And so a lot of times doctors presume that a patient doesn't understand what we talk about, so you're like a black box, we give you a pill, you respond, you get better. It ain't working like that. What you need to understand is that you have to be proactive in your care. If there's anything I want you to get from this talk today, is how important it is that you engage your physician, and sometimes you might have to tell him what needs to be done. Now, what I mean by that, that means I'm not saying you're going to tell him what chemotherapy you're going to get, but that in particular, you need to take care of yourself and say, look, I need to have colon cancer screening, or I need to have prostate cancer screening, or I need to have breast cancer screening. You have to be the one responsible for your care. I'm going to state that from the gate. The second thing I'm going to do is I'm going to sort of highlight sort of some basic science that's involved with cancer. Like I said, educated patient is a good patient. And what I'll do is I'm not going to go through all the chemistry and everything else, but what a cancer is and how it develops. From there, we'll go on to how we diagnose, and that is where your responsibility comes in, as well as your physicians, about how we screen for colon cancer. I'll talk briefly then about, after screening, what do we do with the diagnosis? And I'll just touch very lightly, because it's a whole field in of itself, what's happened from 1994 to the present that allows people to have stage 3 colon cancer or breast cancer now walk on top of the stage now, which we'll see in a few minutes. So what I normally do is that I'm going to do it this way. You see the slide up there? And Reverend Rogers, can you advance? Okay, good. Okay, so I was a chair for the Florida Cancer Society, American Cancer Society, for about 10 years. And so they've worked very intimately about making sure education gets about. So a lot of these slides come from them. Advance slide, please. So we talked about what I want to do and also about how we're going to go ahead and approach this next slide. And key things which advance in this. What I'm going to do is go advance, please. And we know this. Okay, so now here we go. Next slide. So I don't have any conflict of interest with regards to the talk. Next slide. So this sign of getting old, I got to stretch over here to see what. Okay. So the key things are these. One is that we have cancer, and what happens that we really aren't aware of what's going on. Part of it is lack of awareness. Colon cancers are internal, so you don't really have a sense of, like even with breast cancer, where a woman or a man, because don't forget breast cancer can affect men too, can feel a lump. And so it's not until it's kind of too late in terms of I've hurt or I'm bleeding that we have evidence that we have cancer. So that's part of the issue right there. There's lack of knowledge about it, because we think cancer in and of itself is going to be this major growth that's there that would represent with bleeding and such. So my goal here is to get sort of awareness of what these symptoms are. Next slide. And statistics, I can tell you that it's the third, next slide. We can see it's the third diagnosed cancer, second cause of cancer death. All these are to say that it's a killer. And that's why we are so adamant about and passionate about making sure people get screened. Next slide. So this is important. As I sort of move into the causes, I want you to understand what leads to the causes, and these are risk factors. We know that as you get older, you become more prone to cancer. That just goes without saying. When you get past 65, the risk of all cancers increase. We can't do anything about getting old, but we can do something about the other events that are influencing cancer. One is diet, and the next thing is activities. We can't do anything about the genes, the race that we are, ethnicity, which have that play into developing cancer. And let me just talk briefly about that. If I had given this talk back in 1994, we'd say about 4% of cancers are due to genes. Now in 2024, we know about 20 to 30% of cancers are gene-related in terms of what we're born with. What determines whether people develop cancer, though, is what the other environmental effects come into play. That is diet, for example, exercise. You've heard it, and I'm going to belabor it again. Greasy foods, fatty foods, high-carb diets, all are predisposing factors for cancer. That's all cancers across the board. Other factors include our exercise, lack of activity, increased adipose tissue. Adipose tissue is fat. Fat in and of itself produces chemicals that produce cancer. Next slide. And so alcohol, number one culprit across the board of most cancers. Cigarette smoking, across the board, number one for all cancers. Type 2 diabetes is, of course, tied with obesity. And that's why that plays into it, because high sugars in the blood cause changes and alter genes or genetic alterations, but most importantly, protein alterations that can predispose to develop these cancers. Next slide. We talked about the genetic, that it's more expressive nowadays. Next slide. Now, I'm going to talk here briefly about a little bit of the science of it. Now, with colon cancers, all cancers, they start from a cell. We all have cells that are what we call pluripotent. That means that it had to come from something. And the initial cells go on to develop everything that makes us who we are. As time goes on, as the development of cells go on, as we become human beings, embryo to child, embryo to fetus to birth, our cells are directed to certain areas, which are the miracle of what God has done for us. Sometimes, though, those cells that are directed go awry. And in a cancer, what happens is you have two things that sort of cause cancer to come about. One is, and I use the analogy of foot is on the gas pedal is stuck and it goes on, so that means that it's constantly producing factors that make cells grow, because what is a cancer? It's uncontrolled cell growth, and uncontrolled cell growth that can move. That's metastasis. So that's why you have the lump in the breast that can eventually become the lump in the brain. That's why you can have the lump in the colon that can eventually become the lumps in the liver because of this spread. This spread is due to the lack of control, the loss of control. Foot on the gas. Other one is lack of policing. It's like the police have gone on strike because normally our body is very smart about policing these cells that are going awry, cutting out the bad ones, and then making sure that they don't grow. However, mutation, those are changes in genes, cause these policing cells not to be there. And then that's when everything breaks down. Next slide. So we talk about the risks and staging. So the first thing that we have with cancer cells, as you can see up here, that you have what are called adenomas. Adenomas are the first stage in which you have these changes that occur genetically. Remember I talked about environment, what you're exposed to, and also what you're born with, your genetic predisposition. When you have the sort of perfect storm of these, that's when you have the first stages of adenomatous polyps. Now, the good thing is that with colon cancer, we can sort of detect these early stage lesions by virtue of different screening tests. And the ultimate test that you want for screening will be a colonoscopy. However, there are ways we can sort of get to that point that might sort of eliminate, for a large part of the population, whether we need to have colonoscopies or not. Next slide. Next slide, please. Okay. So this is a view from in a colonoscopy. And this is what you see, that sort of very sort of velvety sort of collection of lining in the colon, that's thick across, is an early cancer cell. I'm usually technology. Oh, okay, good. So what this is what I had done with my colleagues at Mayo. We were some of the first physicians to take these flat lesions and are able to remove them because these flat lesions have genetic abnormalities that can go on to lead to development of cancer. And we do this, this is the type of procedure called endoscopic mucosal resection. And that where we remove it, and now we can put clips on that. In the old days, prior to, let's say, 1980 in particular, you'd have to go to surgery with polyps being seen. Now the vast majority of these polyps can be taken care of endoscopically, that is, just with a scope. So, primary goal, cancer prevention. Cancer prevention is by screening. Now, 3 ways to do it. I'm going to talk primarily about scope and stool. Scanning had its heyday probably in about late 1990s and early 2000s, but they found that it's not very effective, and that for the most part, it's like the problem with any imaging. You're just getting black and white pictures. You want to have something that's going to have some corresponding sort of marker. And that's where the stool studies come into play as an adjunct for the scope. So, even though we do colonoscopies, there's no gold standard for it. It's the gold standard, but we still can miss about 5 to 10% of lesions. But it still has the advantage of what? Being able to remove the precancerous growth. And that's the reason why that's so important. Now, what I'm going to do is I'm going to just get to the heart of the matter, because I don't want to take all night. Like I said, I'm talking about this for 30, 40 minutes. There are sort of 2 major ways we ascertain whether people have colon cancer. One that you've heard of and that we push because it's, again, a way we can not only diagnose but remove the lesion is a colonoscopy. We drink the fluid, clean out your colon, we go up with a scope, we see any polyps, we take them out. You see a cancer, hopefully we find it early enough, mark it so that the surgeon can take it out if it's too big, or if it's a cancer in and of itself, remove. The other study that's come about, I'm going to give you a quick evolution, is that initially, if you might remember, all of us, if you're my age, fecal occult blood testing, where they say, take this little tablet home and put some stool on it and see if there's any blood. We found that that was very sort of non-specific because so many things can make a false positive. Flash forward to what came about in the early 90s, which we knew that, as I mentioned about the changes that occur in the cancer cells and the polyps, we're able to now to detect those genetic changes in the stool. And from that, it's called, we can see if people need to have a colonoscopy on the basis of whether it's positive or negative. It's about 92% effective. One that's on market now is called Cologuard. There are a few others that will be coming down the pike. But the advantage of this is that if you have, and this is what's important, if you do not have a family history of colon cancer or you have not had polyps in the past, this is a good study because it's 92% effective about detecting if you have a polyp or a cancer on the basis of your stool. If, though, there is a strong family history, first-degree relative, or you've had polyps in the past, it's not a good study because what does the study do for us? It's going to tell you whether you need a colonoscopy. If you had a polyp in the past, you're already going to have increased risk of having polyps in the future. Same with family history. That's why we generally relegate that to people who don't have that problem. Next point, I think it's important, is age. Back in 1994, we'd say 55 would be the starting point. As you've heard in the news, cancers are being detected in younger and younger individuals. So now we're saying 45, particularly for African Americans, because we have sort of genetic predisposition and also epigenetic, which is another talk I've given before, about how stressors and other factors can lead to that. But suffice to say, early detection now is the modality, 45. So I don't belabor and take up everything. The other point I want to make is that it is now a curable disease, even if it's cancer, it's caught early. As I'm sure my next co-speaker is going to talk about being a survivor, how important it is that medical advances have been done. From the I can tell you the transition point. When I first started GI oncology, we only had 2 chemotherapeutic treatments. One was 5-FU, was the mainstay. Now there's a whole slew of therapies that are done, including something called biologics, immunotherapy. All these work together to make it, as I said, from a death disease to a chronic illness. And so that's what's so important. I'm going to stop because I believe we're sort of having an interactive point, and after we all get up here, we can talk some more, and And I'll be glad to answer questions about some of the newer things that are done and other sort of newer tests for screening them.
Thank you so much, Dr. Woodward. And so now I'm going to bring up our next guest, which is Mr. Terry Payne.
I appreciate you having me here. It's really important because, like you're talking about the detection, and I've been cancer-free since 2007 now. But like you heard from my bio, I was in the Navy for 20 years, and when you're in the military, you only have one place that you can go to see a doctor, and you can't. It's just not like the civilian world where you go get second opinions and third opinions. And being a guy, you know how we are. We get those symptoms, and we like, it's not a big deal. Well, my wife pushed me in so I went in on a Sunday, and Sundays are in the hospitals, you're a little understaffed, and they're really busy. And I had the unfortunate of having bleeding hemorrhoids. And so I said, well, okay, I got hemorrhoids, but what I didn't know was I had the cancer too. And because I had the doctor seen, or the PA seen the hemorrhoids and there was blood, they just assumed, okay, you just got the hemorrhoids. So fast forward a year later, I retired, and my wife says, you're going to go back and get checked again. And they came out and they said, yeah, you've got cancer. So I went through 6 months of chemotherapy, 3 months of radiation, and I was in a study. They used a Avastin on me too, which was, I think, to keep oxygen from the cancer. So my cancer's gone. And then a couple years ago, I went ahead and did I had my genetics checked because I've got 2 sons, and I was worried about them getting cancer. And luckily, it's not genetic, even though my grandmother had it and my sister had it, but they said it's not genetics, it's just from probably our lifestyles. And then I do have side effects, so that's why I want to encourage people to, when you get the symptoms, follow up on it. And like say, if like in my case, they thought I had the hemorrhoids. Well, if your symptoms don't go away, follow up on those symptoms. I even have, like now, I went and had a PET scan a few months ago, and it came back, and they seen something there, so they said, well, you need to go back and see your gastroenterologist. And then they did a stool sample, and they see a little bit of blood in there. But being a guy, I'm like, well, I have a fissure in there. And that fissure is giving me a little bit of blood. So, here all the time, I thought, is it a fissure or is it something else? But I have been following up on my, last year I had 2 colonoscopies last year because of the problems I'm having from the side effects. I'm in pain a lot. So, but the cancer's gone. Not sure what else more to say other than the fact that you definitely get that screening. Don't be ashamed of going in and seeing the doctor and following up on all those symptoms, because I was so glad that when I went to I did the tour at Mayo last week, and I was so inspired to see the technology they got there was, because when I did my chemotherapy, I went in 3 times a week, but when I left, I had a bag with a pump. And I had chemotherapy pumped in my body 24 hours a day. I was going in, I was getting the radiation. And I was one of the lucky ones because I was retired military, I had a paycheck coming in, and the VA was giving me disability checks. So I was going with people that didn't have that. They didn't have that backing. They were trying to work and go through the chemotherapy and all at one time. So with the new technology I see and the way they're able to put the cells in the mice and rats and find better cures for people, I was just so inspired, thinking, I'm so glad that people may not have to go through what I had to go through and all the side effects. About all I got, I guess. I mean,
Thank you so much, Mr. Payne, for sharing your experience. So next, we're going to play a short video that we have from Dr. Jeremy Jones.
right, thanks again for our speakers today. We're going to actually take a few questions if you have any. Anyone have any questions for Dr. Woodward or Mr. Payne? Or comments?
All outpatient. But I want to follow up with what you had talked about, earlier, which is very important. When it's symptomatic, it's kind of too late. And I want to state that, and I want to reinforce that. It's been very helpful because what you've gone through is what we want to try to avoid. And I can't stress enough the importance of, and I've had so many people come in attributing it's hemorrhoids, and then it's cancer. So importantly, if you do have blood, run to your doctor. Remember I mentioned earlier about, I'm sorry if I'm reinforcing this, but it's very important. Be insistent, but also be insistent about the screening, because you don't want to get to the point where there's blood in the system. And like I said, 45 is the age to start. So I'm sorry, I want to reinforce that you brought that on. Other question? I'm going to ask. Yes. And what's interesting, interestingly, the rate of colorectal cancer has decreased. However, the age of onset has gone to lower ages, such that 20 years ago, the average age of the patient with colorectal cancer was about 50, 55. Now it's gotten to lower to 45, and we're seeing it. I have a very good friend of mine in town whose son, he's a physician, whose son died from colon cancer at 32. And if you remember in the news about 5 years ago, there's been this sort of explosion of young people getting colon cancer. Why? But you can attribute everything from hormone and milk. We don't know what it is, but, and I just know that. I'm not saying I don't want the milk board come after me, but I'm just saying that there are environmental changes that have come about now that we didn't have before. Sure. I mentioned that earlier, but I think it's very important that we reinforce that. Family history is a major component. First-degree relatives put you at a markedly increased risk. Even though you did genetic testing, what we're finding as time goes on, there are a lot of genes that we didn't know about that are coming to fore. And so if you have a number of relatives, so even if they aren't first degree, let's say you had an aunt or uncle, but you had several aunts or uncles, we have to be thinking a little bit more about it. Another point, too, that's key is that it's not just colon cancer that will have this sort of association. There are some cancers that sort of come in, that go and pass. For example, Lynch syndrome, we think of it with colon cancer, but it has genetic abnormalities that can cause cancer in other parts of the body. Thyroid, for example, urogyne malignancy. BRCA gene, which you probably have heard of with regards to breast cancer, on the flip, is also associated with both breast as well as colon cancer. So these are factors that you have to keep in mind. If you have fat cancer in families, think about that. I mentioned earlier about African Americans have a higher incidence of colon cancer. They have a higher incidence, unfortunately, of all colon cancers across the board, which again reinforces the importance of screening. Screening, screening, screening. Go ahead.
You go in, the doctor does a procedure, and you wake up and get the results. And you don't hurt, you don't do the whole thing. So I put more people not feel because they're afraid of it. On my own patient, it's all
Right, which is what, and that's important though, is because I didn't go through all my slides, obviously, but so what is the main cause is that a lot of times their primary care physician has not brought up to the patient the need for screening. So again, reinforce, you really have to be proactive in this regard. The other thing too is the advantage of the stool test is for that discomfort, perceived embarrassment, perceived of doing a colonoscopy. But we do know is that if we find that test and the data shows, we show you that this is what happens if you have a positive. That makes it a lot easier. So the rationale for doing the stool test is to lead you, if it's positive, make sure that you get that colonoscopy because it's telling you it's cancer. So true. Mm-hmm.
Father had colorectal cancer, but he survived the treatment and he's well today, very well. The thing that I would ask is, I have my colonoscopies done as prescribed by the doctor, and each time they have found polyps. Now, it's no bleeding or any of that. Does that mean that cancer is somewhere around in there somewhere?
What it means, which shows the efficacy of doing colon screening. Polyps, this was a study that was done at Mayo back in the 50s. A polyp that is a centimeter in size takes about 10 years to become a cancer. So with the detection of those polyps, when we see them, we don't just sit and let them grow for 10 years, we take them out. And that essentially removes that cancer risk from that polyp. What it also tells me, though, is that you are predisposed to forming polyps. And that predisposition, be it genetic or environment, means that you need to be on that surveillance. This is not screening now. You're on a surveillance program. It should be at most, I'm just talking about you, every 5 years. And a lot of it is contingent upon how many polyps are found and the size, about how short the interval is. But that's a very good point, how important it is about family. Again, I go back to what I said, breast cancer, pancreas cancer is sort of a cloud of the way this works, that you're predisposed and that should be more wary when you have cancers overall in the family. That's it. He does want you to go back every 3 years. A lot of it depends on how it looks under the microscope. So, for example, in terms of the science of the polyp, the way that polyps grow is that they sort of are very most cells are very orderly, and they're, like checkerboard. Okay, everything's set up right. When polyps start to grow, they become irregular. So instead of being a square, it starts getting odd shapes and such. And the more odd it becomes, the more likely that we worry about it being irregular or bad. So there are tubular villus adenomas and villus adenomas. And so they sort of have a progression in terms of severity. That might be the reason why. Secondly, it could be the size. A polyp greater than a centimeter raises more of a flag that this might be a fast-growing predisposition. So that's probably what you have to do. Yes, but as Terry attests, you don't want to get to that point. Okay, and so if you have symptoms, it's kind of like the horse is out the barn. Okay, you have cancer. It could be a large polyp, obviously, but yeah, the symptoms will be bleeding, rectal pain, weight loss. It's sort of the cancer, trial that you worry about. But that's the most important thing to get out of this. Me talking tonight is that I don't want to see you all coming in with symptoms, and here I am. Then that's kind of a little bit late. I want to catch you. The doctors should want to catch you before you get to that point. That's why I stress the importance of screening. Payne could be, okay, could be one. But again, that's, yeah, because it's size. I mean, a lot of this is size dependent. You have something that's big and growing, what does it do? Real estate's tight, okay? So you have a big mass that's sitting up there blocking the colon, you get obstruction, and that can lead to pain. Okay, so that's why what we would want to do. The other thing too is that for people like it, but in fact, several studies that show, you know what makes a man go to the doctor before his colonoscopy? The woman is. And that's because, you know, and I'm glad that you were there for him. But to sort of help facilitate, that's where Cologuard comes in, is that, look, this is showing you that you have something. That's a little bit of, you know, that's what might need to be done for that. Sure.
Thank you so much for all your questions. And for those of you that are virtual, we're going to do our best to get back to you as soon as we can with the answer to those questions as well. So feel free to send them in the chat. Next, we're going to proceed with our short video by Dr. Jeremy Jones.
Third most commonly diagnosed. It usually arises in the inner lung. It's one of the most preventable cancers.
So the way diet plays into it is that there are several things. One is that our carcinogens that are present. And then there are sort of proactive agents that aren't necessarily cancer causing, but they sort of potentiate or boost up. Case in point being this, it's been thrown out that hormones, for example, in milk and food products and meats may be a contributing factor because there are growth enhancers, growth hormones. They sort of potentiate with other active ingredients or agents that are in the cell that can sort of push them to become cancers. Increased carbohydrates can work by adding fuel, so to speak, to the fire. So diet plays that. That's why the people out in the north, for example, take Osaka, Japan, where they have Okinawa, where they have a low incidence of cancer, long life, lower carbohydrates, lower caloric intake in the diet. Well, compared to carbohydrates we get when we go to a Burger King, I'm sure that it's going to be different. Also fats that are also present. And they have, and nobody knows if there was a magic bullet, because everybody's looking for that one thing I need to take that will decrease cancer. Currently, we talk about using turmeric. Have you all heard about turmeric? That's been shown in some studies to sort of decrease cancer progression or development of cancer in people who have genetically predisposed factors that count for cancer, such as familial adenomatous polyposis. But you have to be careful, because I can tell you in the evolution that I've been doing this, there was a big push in the early 80s and pretty much to the 2000s about antioxidants. Well, they've been found to actually potentiate cancers in the lung. So everything is within moderation. I think that's the key thing. So even with diet. You got the slide? Okay.
Thank you so much, Dr. Woodward. Okay, so we're going to try our second attempt.
Colorectal cancer is the third most commonly diagnosed cancer in the US. It's the second leading cause of cancer-related deaths in both men and women. It usually arises in the inner lining of the large intestine, which includes the colon and the rectum. Patients with colon and rectal cancer usually present with similar symptoms, although there are some differences in treatment. I think colorectal cancer is a cancer of missed opportunity. It's one of the most preventable cancers, yet 1 in 3 persons who are eligible don't undergo the recommended screening tests.
Traditionally, colon and rectal cancer are thought of as a disease of the elderly. Over the last 20 to 30 years, unfortunately, we've seen a shift, a significant shift into patients that are quite a bit younger than 50 years old. In fact, if you look at the incidence of colon and rectal cancer, for patients over the age of 50, we have seen continued decreases in the incidence of colon cancer.
The exact etiology, pathogenesis of early adult onset colorectal cancer is still unknown. So given this change in trend, so increasing incidence of colorectal cancer in younger individuals, the American Cancer Society has recommended that we decrease age of average risk screening to 45 years.
So some of the signs of symptoms can be quite subtle. Oftentimes, patients will present with a lot of fatigue. Other symptoms include abdominal pain, cramping or bloating, change in bowel habits, so having to go more frequently, or thinner appearing stools, again with increased frequency.
I think the important thing to realize is that majority of patients who have early colorectal cancer are completely asymptomatic, and that's why screening tests are so important for early detection. But in someone who has more advanced colorectal cancer, there can be some symptoms and signs. These include rectal bleeding, change in bowel habits, patients can develop abdominal pain, unintentional weight loss, and then they can also have lab abnormalities, most common being iron deficiency anemia. Other risk factors include a family history of colorectal cancer, especially 1 or more first-degree relatives. There are several genetic conditions that can predispose to colorectal cancer. the most important ones being familial adenomatous polyposis syndrome and hereditary non-polyposis colorectal cancer. And then finally, patients who have underlying inflammatory bowel disease, so either ulcerative colitis or Crohn's disease of the colon, are also at risk for colorectal cancer. In addition, there are certain modifiable risk factors which mainly pertain to diet and lifestyle.
One of the most common situations that I see is in a younger patient who's had complaints of either blood in their stool or painful going to the bathroom. They have been told for sometimes years that it's either hemorrhoids or they're too young to have colon cancer. And unfortunately, by the time I see them, their cancer is very advanced. And so I would say, from a patient standpoint, I would try to be an advocate for yourself and try to, if the symptoms are persisting and not adding up, I would continue to press. The classic progression from polyp or colon non-cancerous colon growth to developing cancer is on the order of a decade. And so that is a perfect setup for being able to do a screening, catch at some point during that 10-year development, and halting the progression.
All right. All right. So I think we have had a lot of great discussion today. Hopefully you've learned a few things or clarified a few things. But I think the main thing that we want to make sure that everyone takes with you is knowledge is power, detection is key. Early detection, prevention is key. So please, we encourage you to have these conversations with your doctor. Ask the questions, even if you don't or aren't aware of or aren't sure of the entire question to ask. Sometimes it starts with, "Doc, I just don't feel right." Or, "Doc, I know it's time for my screenings." And you initiate the conversation. There's absolutely nothing wrong with that. So thank every single speaker we had. Thank all of the questions that we had. I'd like to just give everyone a round of applause for being here. And, you know, again, thanking Dr. Woodward for sharing information on the subject matter, Mr. Payne for sharing your story, and Nicole for moderating. So what we want to do now, I think everybody has had an opportunity to complete the evaluation. Please go ahead and turn that back into a Mayo team member. The Mayo team members are everywhere, so if you are a Mayo team member, just walk around and grab those post surveys. I think Reverend Rogers might be at a point where he can come say hi, bring greetings. So we would love for you, sir, if you can, just to give us a brief greeting. Let's welcome Pastor Rogers.
Thank you so much. Hey, thank you everyone for coming tonight. Thank you for being here. We really were hoping for a communication, a conversation to start in our community. It is no secret, and Mayo's just too nice to say it, but healthcare in our community is not where it needs to be. And we know it, we've seen it. And again, when it comes down to issues of healthcare, when America gets a cold, the Black community catches pneumonia. It shows up so much stronger in our community, which is why we really wanted to have a good, significant amount of people here tonight so that we could start this communication. One of the things that the doctor said was real key was who gets us to the doctor, particularly as men. I said it on yesterday, and I'm disappointed with our turnout because this is important. This is very important. We have an epidemic in our community that you could just say any health-related issue, you have the word disparity that comes before it. or after it. Diabetic, disparity. High blood pressure, disparity. Infant mortality, disparity. And all cancers, disparity. And a lot of that is simply because our awareness is not there. We cannot continue to lose good people when the science, the technology, the innovation is there, that a lot of us will make it if we are caught early. And I told the church on yesterday that my best friend from college just died a month ago from colon cancer. And he was a multimillionaire. So it's not an issue of your economic status. It's not an issue of your race. It shouldn't be. It's an issue that we are not aware of our status when it comes to health-related issues. So this is important. And again, I'm disappointed, but I'm happy for everyone that is here, because those of you that are here could put your hands on 10 people and make sure that they know what we heard tonight, that we must fully be aware. So Deacon Weller, Deacon Parker, y'all gonna have to protect me, because I'm gonna tell the church Sunday that they let me down, okay? They let me down. And when they get mad because somebody didn't go to the hospital, they good at that. But when somebody tries to keep them out the hospital. So let's get this right. Flyers went out, information went out all across our town. And we have to understand that we are in a hot zone when it comes to these health-related disparities. So if we're going to make a dent in this, we're gonna have to do it one by one. So again, Mayo, thank you for coming out. I think you brought more people than came tonight, but we wanna make sure that this information does get out. So we also hope that this is the first of many conversations. I stopped doing Zoom at the church about 2 years ago. So I had to find Zoom again, reload Zoom, and it was making all that noise because I had Zoom in the church as well as on the broadcast. And so it was looping through, and I'm like, there's no speakers on. Why is it feedback? It's doing this. So y'all, thank you. I know somebody was praying because I was ready to throw everything out the window. But I think it was a great success still. So thank you all for coming. Thank you so much. I'm thankful that we have our new city manager in the back who is here showing the support of our city, who cares about what's going on, amen, and how we can definitely partner. Now, I got to say this, and I'm just one last thing. Our turnout is absolutely part of yesterday was Easter. And a lot of church folk are tired because we were getting ready for Easter. So I give them a little bit of grace with that, but I hope we're able to do this again and get it in front of a lot more people, because you guys, Mayo, thank you. You are saving lives. Every time you go out, your story tonight helped somebody that you may never even see again. But you saved a life tonight. You let somebody know that this is what it takes so that this brother, this sister will be around for more and more birthdays. So again, thank you. Let's everybody give our Mayo friends a hand clap of encouragement, and thank you again. And I can't thank Chelsea enough for all that she has done, staying on me, and we're gonna get it better next time, but thank you.
Thank you, Pastor. Thank you so much. We are coming up on the end of our time together, so just wanted to encourage everyone to be an advocate. Be your family's health advocate. Signs, symptoms, get screened, ask questions, and thrive. So again, thank you all for joining us today. This was our first time hosting Cancer Conversations in a hybrid setting. So please give yourselves a round of applause. Thank you for your patience. And as Pastor Rogers mentioned, we are going to be working through this together to have and bring more conversations to Putnam County. No worries, we will be back. This is not enough to scare us off. This is way too important. But we are so grateful again to Pastor Rogers and the Bethlehem family, Shannon Denson and Jacksonville Black Chamber of Commerce. Thank you for collaborating. Mayor Correa, thank you for being here. Let's give her a round of applause as well. The whole mayor is here, y'all. I think you could do a little bit better than that. And so we have a lot of work to do, and we need to work together to reduce cancer burden in our community. Today's Cancer Conversations was recorded and will be shared with those who registered. We do have refreshments, light refreshments, not Easter dinner, but we have light refreshments over in the fellowship hall. We invite you to please join us there. And if you're interested in sharing your story, if you are a survivor or a caregiver, like Mr. Payne shared his story today, please let us know. We'll be more than happy to get you connected within our speakers bureau and for other conversations that are coming down the pipe. Also, if you're someone who's interested in helping our researchers design various studies, you know, we have an opportunity for you to pair up with a researcher, understand the concept of what their study or their idea is, and help sort of guide the conversation as they're developing their study. If you're interested in doing that, please let us know. We're happy to get you connected through our Cancer Conversations and our community engagement studios. And lastly, if you are someone who's interested in being part of studies or learning about what studies are available in your community, you know, we have something that's called, we have an initiative called the Community Research Registry. And scanning the QR code or connecting with one of our team members, we can get you signed up for the registry itself. It does not automatically enroll you in any study, but it just makes you aware of what studies are available based on your profile that you create. So any one of us are happy to share that information with you. Again, thank you all for joining us, and this concludes our presentation for tonight. Thank you, and get home safely.